Good morning again, ladies and gentlemen. And I'm going to be speaking today about endometrial cancer. And endometrium, for most persons, is that section of the uterus that during your reproductive years, it sheds each month and comes out as menstruation. So that is the endometrium, which is the inner lining of the uterus. Like anything else, you can get cancer. Every part of the body can get cancer, and the endometrium is no difference. And so endometrial cancer starts in the endometrium, and it is more common than people believe. The Kingston and St. Andrew Cancer Registry 2008-11 showed that endometrial cancer is almost 15 per 100,000 per year. Now, it is the fourth commonest cancer in female. Behind breast, first, cervix, second, and colorectal, third. In that same period of time, all the cancers that occurred, now that's incidents, now those that were there before, were 2,069 males and 2,078 female, which is about the same. The female have us out by 9. Now, with prostate being what it is, I thought it would be the other way around. Now, in the USA, the incidence is 27 per 100,000 per year, and is the most common female cancer, more common than cervix. And people are wondering if it is related to the epidemic of obesity as one of the risk factors. It is rare in young women, so women who are menstruating hardly get endometrial cancers. It happens occasionally. I've seen it in 28-year-old, I've seen it 35-year-old, and in most cases, sometimes those are the ones we miss, or if we don't miss it, take a little time because you do not expect it in that age group. And it is the most common symptom in the postmenopause. The most common symptom is postmenopausal bleeding. Now, occasionally, endometrial cancer is found just on a routine ultrasound, since you know that we have a lot of imaging these days, and people get imaging for all sorts of things, pelvic pain, etc. And you hear sometimes that the endometrium is thick. And when you see that and there is no symptom, you want to find out why this endometrium is thick, especially in women that should have thin endometrium, that is after menopause. The other thing you can notice, although postmenopausal bleeding is common, whenever you have the younger postmenopausal women with bleeding and have menstrual symptoms, they usually do not have cancer. And let me explain this. Suppose menopause was at 51, and we say if you have no period for a year and you start to bleed, you need investigation. But occasionally, a few women will go to 53, 54, and they have a bleed, one bleed, and they tell you they had breast tenderness, they had belly button pain, and everything like a period. You shouldn't really ignore it, but it is reassuring when it feels like period and when the person is younger. You wouldn't expect that in an 80-year-old. So some of the risk factors that we know about: early menarche, that means the commencement of period early, and the late menopause. And we look at that at women who start have periods, say at age 9, and menopause after 55, and those. And the easy explanation is that there's a long period of having exposure to estrogen. Obesity is always there. And obesity, the heavier the worse. And you know that obese people do produce extra ovarian estrogen in their body fat, which is broken down eventually by your adrenal gland to become estrogen. Diabetes also have that sort of mechanism too. Unopposed estrogen replacement therapy. So ladies who have bad postmenopausal symptoms and want hormones, if they have not had a hysterectomy and they get estrogen, what I put as unopposed, it should be estrogen and progesterone. Estrogen, because if they take straight estrogen, they are more likely to develop endometrial cancer. Polycystic ovarian syndrome, which is something that we have fairly common in our society. And some of the younger women I have seen with thick endometrium, endometrial hyperplasia, and subsequent endometrial cancer. And they were not even postmenopausal. There were known cases of polycystic ovarian syndrome. Nulliparity, it's good to have a baby here or there. It doesn't mean that it will protect you altogether, but it is also one of the risk factors. And you will understand that if you have no children, never been pregnant, that break in the cycle of period, no period, pregnancy, no pregnancy, all of that, that is not there. And so there's a contribution there. Then some people have some of the hereditary factors, which I'm not too sure if that is common in our society, but associated with non-polyposis colon cancer. And you get it like in the so-called Lynch syndrome, where women have certain glandular cancer, ovarian, colon, and endometrial. People have had to get radiation, low, especially low dose radiation, not strong radiation, but people do get low dose radiation for various reasons, and there is a little higher risk. And at the bottom, treatment to prevent recurrence of breast cancer. So women who are taking stuff like tamoxifen, there's no doubt about it that they develop more endometrial polyps. The good news, however, is that these endometrial polyps are usually benign. And so the one study will tell you that, oh, it doesn't cause anything, although it causes a lot of polyps, but not really cancer. So tamoxifen treatment. So the way my surgeons send their patients to me as far as tamoxifen treatment is concerned, when I see, and we do a hysteroscopy and a biopsy, and most of them have no endometrial cancer at all. But it is worthwhile noting because as your recent chum said, the treatment shouldn't be worse than the disease. The diagnosis itself is based on history, examination, and investigation. The main history is postmenopausal bleeding, but any abnormal bleeding that is not cyclic should still be investigated if a person is not menopause. Then another thing that you find in the diagnosis, occasionally we do a procedure like hysterectomy for fibroids. And lo and behold, when the lab result comes back, there is endometrial cancer. Not common, but all of us who have been along long enough will get a case or two of that sort of stuff. It is even bad when everything went against your recommendation. And I have a particular case I can remember. 46-year-old, had a lot of fibroid, wanted a myomectomy, didn't want a hysterectomy. And we did a myomectomy, and she had some submucous fibroid that was inside the uterus. And when the histology came back, endometrial cancer was there. Of course, she went on to do a hysterectomy like about 6 weeks later. The examination, there's no specific finding, but some women who have blood in the uterus or pus, or when they examine the uterus, feels enlarged and globular. But one thing that the books doesn't tell you about, and I'm sure Dr. Bambury and Taylor would have seen it, a woman with endometrial cancer, she's 70-year-old, she's supposed to be fairly dry. You pass a speculum and there's a lot of slimy mucus. It is a warning sign. Now, the real crux of the matter is to get a sample of the endometrium to prove what it is. And most of it can be done in the office with little instruments, more like small drinking straw that you introduce up in the uterus and get sample. And if it is positive, you are great. If it is negative, maybe you miss something. So it doesn't mean that it stops there. If you are somebody who does hysteroscopy, it is a very good thing to do because all you do, you're going to introduce a little hysteroscope and look in the uterus. And sometimes you don't even have to do a biopsy because it is so clean. But sometimes you do hysteroscopic guided biopsy. And the good old DNC, which was all that was around when I started practicing 44 years ago, where you open the cervix, which means D, dilate, and C mean curettage, and the patients call it DMC. And but what you do here is scrape the lining of the uterus and send it to be tested. Now with imaging more common these days, and the first ultrasounds only came into medicine in 1980, and they were obstetrics tool, but the resolution got much better. Then vaginal probes came around, and so we can look at hard tissues now. And so you do imaging if somebody has a bit of postmenopausal bleeding. If the endometrium is less than 5 millimeters thick, and that means double layer, because the endometrium, if you put your two hands together and you think about the skin in your palm, the thickness you get on the reading is not just one palm, but both. So if it is less likely. It doesn't mean that you won't investigate it any further, but you are seeing the patient because many times people come with postmenopausal bleeding, and it could be coming from rectum, it could be coming from urethra, it could be coming from vaginal wall, and it could be postcoital, which could be just rough intercourse. So you will use your clinical judgment. It is not just a matter of ultrasound. If, however, the endometrium is thicker, the double layer, than 10 millimeter, then there is a strong possibility that we either have endometrial hyperplasia, which is not cancer, it's just a thickening, and you have endometrial cancer. Of course, there are other things that the imaging might show, things like pyometria and hematometria, meaning pus or blood collect in the uterus, because a lot of elderly 85, 90-year-old, the cervix is so stenosed, meaning close up, that the uterus gets enlarged. And if you get a little dilator, and if you can, you are surprised sometimes pus goes out at you or blood. So all of those are things that imaging can help you in terms of your diagnosis. When you get your biopsies, either going to be one or another. The thin ones and the bleed are atrophic, mean a thin lining. Sometimes if you do a hysteroscopy, you can identify that very easily. But that is reassuring, and in most cases, you reassure the patient, but you still tell them that if it should happen again, you'd still need to be checked, because not because it's atrophic. No, it could be something else 6 months or a year down the road, not like what hypertensive people who go to the doctor and they get one dose of medication for the blood pressure and they say they cure, and 10 years time they get a stroke and never take another blood pressure pill. This is how medicine is. Then we see the hyperplasias in the lab report, and they can be simple, which is not usually malignant, but they can be complex. And when you get complex hyperplasia, it can have atypia or without atypia. And so the atypia is a more sinister one. Then you have the endometrial cancers and histology theories. That could be a whole lecture itself, but it can be well differentiated, that means clean, a good cancer, put it that way, or can be totally undifferentiated, mean all the cell types are not even related. And then you have histological types, like endometrioid, which again is a good one, but you can get clear cell types and sarcomas, which are not good types. So the management, having made a diagnosis, if it is malignant, the primary treatment is hysterectomy. And, and it usually goes with taking out the tubes and the ovaries. We get from time to time, it has happened to me, and I give you an example, a diabetic lady, obese with amputation and everything, and she had the biopsy show something that was well differentiated, and she had a heart problem too. Nobody wanted to do any surgery on that lady. So we put in a levonorgestrel releasing intrauterine device. The ones that the common one in Jamaica is Mirena, but there's one also called Lilith, which is a bit smaller. And the progesterone is released directly onto the endometrium and differentiates it. In other words, literally reverse the early cancerous changes. Can also be used with the hyperplasias too, but they need regular follow-up. Then the surgery is either going to be abdominal, which is laparotomy, or laparoscopic. At first, people used to say you can do laparoscopic. Not so anymore, because what you do, you can do lymph node dissection and everything laparoscopically, but do not morcellate the uterus and take it through your puncture site. So the uterus is delivered through the vagina. Because most of you knew that Johnson & Johnson was taken to court by a doctor who wanted laparoscopic surgery, and the uterus was morcellated, and then later on, the puncture sites had secondary cancers, and that one went a long way. Vaginal hysterectomy, can it be done? The disadvantage is that you cannot do the lymphadenectomy that maybe you'd want to do, remove the nodes. However, it can be done because I have had about 2 patients I can think about who had big 3rd-degree prolapse and had postmenopausal bleeding, and the uterus wasn't too big, did a biopsy and did their vages, and they have done extremely well. And a study from Italy, there are more than one, where they do a lot of vaginal hysterectomy with patients with high body mass index. They use it. But now that we have PET scans, they do PET to see if there is node involvement. And if there is negative node, they can say, well, we don't have to do any lymphadenectomy. So take out the uterus vaginally. Because these big, heavy patients, it is a better way to do it. Less morbidity. As a matter of fact, sometimes even less than laparoscopic, because you don't have any punch or cut in the abdomen. Of course, when the hysterectomy is done, the surgeon et al. Will decide whether you need adjuvant radiotherapy, depending on stage, or you need to go on to chemotherapy. And the stages are really simple, and this is a simple stage. It's not, it is bigger, more in depth than this. But when it is stage 1, it is confined to the endometrium, like the picture I showed you earlier on. And if there's any invasion in the myometrium, it is less than 50%, 1A. Then you go to stage 2, where the cancer actually go into the endocervix, but it isn't outside. And the stage 2B, it go into the stroma of the cervix and have to be treated like cervical cancer. Then the stage 3 now, you have the tumor extend from the endometrium, like from your pear seed, straight out through the skin of the pear. So goes from serosa, and the oncologists usually do peritoneal fluid. So you get eccentrically serosa, positive peritoneal fluid cytology. The tumor can also go to the vagina in stage 3, and of course, pelvic and para-aortic nodes. And the stage 4, you can be into bladder, bowel, inguinal nodes up in the groin, which is an uncommon site, and you can have distant metastases, which will need something totally different. So all in all, I'm winding down, the prognosis is very good. And there's a 80 to 95 or 85 to 90% survival 5 age in a stage 1. As a matter of fact, it is even more than that, but you know, we like to discuss survival rate in terms of 5 years. I know people who have had a simple hysterectomy, had a stage 1 cancer, and they're alive now, years later. Some died from stroke, motor vehicle accident, and not the cancer. When you do hysterectomy with your lymphadenectomy and then add radiation where nodes are positive, sometimes you're dealing with patients with a prognosis maybe down to 60%. And then when you get the distant metastases, and there's a weird, more than one, but one that you don't like, that you call it clear cell endometrial cancer, or this you get from your histology. Sometimes you can find secondaries in the lung before postmenopausal bleeding. So those are patients that know in years gone by, endometrial cancer was only treated with high dose progesterone, but people are going into chemo now. Some of the complications are related to the fact that a lot of your endometrial cancer patients are elderly and have pre-morbid conditions. So you can get more bleeding at surgery. Although our surgeons know, most of them don't even transfuse. I have noticed that. Venous thromboembolism, and that is fairly common, especially when you have to do wide dissection, including lymph nodes and all of that. So a part of the treatment is prophylaxis against thromboembolism, and it can occur all a good while afterward. I had a patient who collapsed and died about 4 weeks after a procedure, although she was an anticoagulant. And then usually, as I said, the complications are related to the fact that patients are elderly, obese, diabetic, etc. So in summary, endometrial cancer is the commonest gynecologist cancer in developed world. And it is felt that it is because obesity is at epidemic proportion and even getting worse. Also, it wouldn't run second anymore because a lot of developed world have screened out the cervical cancers. So while we have cervical cancer ahead of endometrial, they have less. Hopefully with our, well, Doctors Banbury and so on, with our immunization and HPV vaccine and all the precancerous treatment, we'll get to the stage where cervical cancer won't even make the top 10. It is a 4th rank female cancer in Jamaica, which I mentioned earlier on, after breast, cervix, colorectal, in that order. And it's about 15 per 100,000 population per year as an incidence, because sometimes you get other figures where people overlap from before. It is uncommon in young women and more common after age 60. Postmenopausal bleeding is the main symptom, and patients will come to you and say, they come to you because of bleeding. Oh, it's no big thing, doc. It's just when I use the toilet, it's on a wipe, I see a little blood in it. People are always in denial. 1 drop of blood is enough to cast a shadow. So luckily, sometimes it is not even the vagina it is coming from. Diagnosis is the bottom line. You need histology. So you have to use whatever method to get a sample of the lining of the womb. Primary treatment is going to be surgery. Complications are related chiefly to pre-existing conditions and age, with obesity being one big problem that you do not want to be operating on people for. And the early presentation is the result why this cancer has a very good prognosis. And so any type of early symptoms, postmenopausal bleeding, should not be ignored. Thank you very much.
Thank you, Dr. Guthrie. I'm sure everyone will agree with me that your talk, as usual, very stimulating and very lucid. Thank you so much.